I'm Peter Block in New Orleans at ACC.11, and with me is Dr. Craig Smith from Columbia. The partner trial, finally, long anticipated, has been presented. Craig, this is a trial which was surgery versus transcatheter valve replacement of the aortic valve. What's the nuts and bolts of what we found?
Well, today we found that with 1 year mortality as the endpoint, TAVR is a very non-inferior procedure to AVR, highly significant non-inferiority endpoint at 1 year. So combining that finding with remarkably low peri-procedural mortality in the TAVR group, particularly the transfemoral group, it's looking very good against a much larger slice of the surgical population than we might have expected when we finished the inoperable cohort. So while the risk profile at an STS of 4 is still only maybe a quarter of the larger population, still it's a big step down the risk profile.
Now, the risk profile in these patients that were both transapical and transfemorals, right?
Correct.
Against surgery. The average score was what? Somewhere around 11.5, 11.8. So tell me about the actual outcomes, because it seems to me that the surgeons did remarkably well.
Well, if you use the O to E as the test for how good the surgery was and use the STS expected predicted risk score as the E and the observed AT as the O, well, it was 0.68, so substantially below the predicted, suggesting that this was relatively high quality surgery. We were very pleased to see that, of course.
Now, there is a little bit of separation of the two lines, the mortality lines at the beginning. Of course, patients have to have a thoracotomy, and that's going to hurt some patients. And then they come together. Explain the coming together business, because that's an interesting issue, isn't it?
Yes, well, that's something people are constantly asking, because the curves do converge, and we don't have enough data, nor was it powered to look past that point to know whether they will diverge or continue to run in parallel or do something else. But it's a very tantalizing observation.
Do you think that probably the comorbidities are manifested by the surgical group earlier on, and then the comorbidities sort of catch up with the TAVI group later and get them into trouble? Is that
that's very possibly the explanation. We weren't really capable of addressing that, but it's a very likely speculation.
Now, everyone, I'm sure, has asked you, Craig, about the stroke business, because in TAVI, there is a higher incidence of stroke compared to surgery, and again in this trial.
Yes.
So what are we going to do about that? How do you put this into the perspective of how we take care of our patients?
Well, from a practical standpoint, what we have to do is make the risk lower as we go forward with better devices and better techniques and experience. In terms of putting these results in perspective, one way to look at it is to note that there are relatively few fatal strokes, and that complications such as major bleeding after surgery, in terms of total numbers, causes more mortalities. The rates may be different, 50% for stroke versus 40% for major bleeding, but in terms of impact on numbers of deaths, complications we already know and understand in surgery, major bleeding, cause more mortality. On the other hand, stroke is stroke, and many people would rather not live than have stroke. It's hard to take that impact away, and it's going to be a focus of attention until we get the rate down.
Well, still a lot to learn about patients with aortic stenosis. My take on it, Craig, very candidly, is that we have a conversation now with our patients and lots of options, which this has shown us. And it isn't going to be a competition. It's just going to be how we talk to our patients about caring for them. Thanks for being here, Craig. Appreciate your time.
Well, my pleasure. Thank you for having me.